So what are anticoagulants? These are the drugs that inhibit coagulation, that reduce coagulation, that inhibit coagulation. They are opposite. These are the drugs that promote coagulation. These are the drugs that inhibit coagulation. So here we want the promotion. So we will give them in bleeding disorder. Here we do not want coagulation. So the person who have a tendency to form thrombus and embolism, I mean, without injury, they form the clot. We will give them, give this in them. So these are anticoagulants. Anticoagulants are the drugs that inhibit coagulation. That's the introduction. So anticoagulants are the drugs that inhibit coagulation factors. So it is opposite. Anticoagulants are the drugs that's inhibiting one of the or few of the coagulation factor, not all 12. There is no anticoagulant that inhibit all 12. Okay, I will tell you the numbers. Which one is inhibiting which one? You should know about the 12. Which one is required at which step? You should be knowing that. You are getting my point. So anticoagulants. Can I start anticoagulants? Let's start anticoagulants. I want this clot not to form. Because if you see my diagrams, you know, my diagrams are perfect. Can you see this diagram? Can you see the endothelial lining? Appreciate. The endothelial lining is continuous. I mean to say there is no injury. There is no injury. When I want to show injury, I show the defect. But here there is no defect. So even without injury, the clot is forming. It's not a clot. It's not a clot. It's a thrombus or it's an embolism. Once it gets detached, it is embolism. So in these conditions, I want to give because I do not want the clot to form without injury. Okay, so I will give them in thrombosis or embolism. I hope you are getting it. So introduction is done. After introduction, come on the classification. The classification of anticoagulants. This is the classification of anticoagulant. People, you have to learn it. It's ultra important. Super duper important. Learn it. Anticoagulants. So coagulants are done. And the definition of anticoagulant is done. After the definition, after the introduction, I'm coming on classification. What is the classification of anticoagulant? The classification, we divide them in two categories, parenteral and oral. Parenteral are given via injection and oral are given orally. Okay, obviously, this one are comfortable to the patient because route is oral. The route is oral, but this one is not comfortable to patient. It is given parenterally, but they are fast acting. Okay, they are slow acting. So there are conditions which varies when we want parenteral, when we want oral. So there are two type of anticoagulants. What are the two type of anticoagulants? What's the classification? The classification is based on the mode of their route of administration. So some of them are parenteral and some of them are oral. There are two type of anticoagulants. They are in front of you. Parenteral and oral. Parenteral we divide in two groups. Okay, direct thrombin inhibitor, indirect thrombin inhibitor. You know, thrombin is factor number 2. Where is factor number 2 required? People, wo chart dimag mein rakho or you make it on a paper and keep it in your hand. Intrinsic, extrinsic. You have to learn it, without which you can't understand this chapter. So 12, 11, 9, 8, 7 and 10, 5, 2, 1. Where is 2? Where is 2? This 2. The name of this 2 is thrombin. Thrombin. Prothrombin to thrombin. Prothrombin is in active form. Prothrombin convert to thrombin. Okay. And 1 is fibrinogen. Okay. Prothrombin convert to thrombin and this thrombin convert fibrinogen to fibrin. This thrombin converts fibrinogen to fibrin. I hope you got it. So this is factor number 2. Appreciate. This is factor number 2. If I say 2, if I say thrombin, I mean 2. And you can see the last one step, we need it. Okay, so these are the one, they inhibit factor 2. Okay, these are the one, they also inhibit factor 2. But they are indirect inhibitor, they are direct inhibitor. So parenteral are of two type, indirect factor 2 inhibitor and direct factor 2 inhibitor. Okay, indirect factor 2 inhibitor mein heparin and low molecular weight heparin, both the heparin as well as low molecular weight, LMWH, low molecular weight heparin. So I will teach you heparin as well as low molecular weight heparin. And two more drugs are there, fondaparinux and danaparoid. Fondaparinux and danaparoid. So total 4 drugs are there, heparin, low molecular weight heparin, fondaparinux and danaparanoid. Okay, so you have to learn these 4 drugs are indirect factor 2 inhibitor. The direct inhibitor mein we are having these drugs. You can see there is lepirudin, there is bivalirudin, and there is agratraban. Okay, so lepirudin, you can see rudin and bivalirudin, rudin, lepirudin, bivalirudin, and agratraban. So I will teach you all these. Okay, these are direct factor 2 inhibitor. But the point is they also inhibit factor 2. They inhibit some of the 12 coagulation factor. So factor 2 inhibitors. I taught you the parenteral one inhibit only factor 2 among all 12. They don't inhibit all. They inhibit only factor 2 among the 12. Some of them are indirect inhibitors, some of them are direct inhibitor, and you have to learn the name of the drugs. So this is the classification for the parenteral. Okay, now coming on the oral. Oral may we are having Coumarin derivative. Coumarin derivative inhibit factor 2, 7, 9, 10. the one which are activated by vitamin K, Coumarin derivative. Okay, there are direct factor 10 inhibitor and there are direct factor 2 inhibitor. So you can see 27910 inhibitor, 10 inhibitor and 2 inhibitor. 27910 inhibitor mein we are having warfarin, we are having bis hydroxycoumarin, we are having warfarin, we are having acinocumarol, and we are having ethyl bis coumarin acetate. Okay, so you have to learn these names. The prototype, if you want to learn, it's warfarin. You want to learn all, very good. Okay, direct factor 10 inhibitor is Rivaroxaban, and direct factor 2 inhibitor mein it is Dabigatran. So you have to learn, basically we are having the anticoagulants of two type. Anticoagulants are of two type, parenteral and oral. Okay, first of all, based on the route of administration. The parenteral are of two type and the oral are of three type. Okay, what is their type? The parenteral is indirect factor 2 inhibitor, okay, and direct factor 2 inhibitor. Okay, so this is also inhibiting factor 2, this is also inhibiting factor 2. This is indirect factor 2 inhibitor and these are direct factor 2 inhibitor. They are inhibiting factor 2. Here we are having Coumarin derivatives which are inhibitor of factor 27910. 27910 inhibitor, 10 inhibitor and 2 inhibitor. Okay, here also if Roman number is giving trouble to you, you can write down normal too. This is how you can learn the classification. Learning the name of the drugs is your responsibility. You have to learn the name. Here we are having the main drug heparin, low molecular weight heparin. Okay, here you have to learn the drugs are rudin, lapirudin, okay, bivalirudin. You have to learn the rudins are there. Here the main drug is warfarin. You have to learn the name of the drugs, main prototype drug in each category. So first this classification should fit in your mind. So parenteral one, we are having two categories, the parenteral and the oral. Parenteral are of two type. Okay, both of them inhibit factor 2. Indirect factor 2 inhibitor and direct factor 2 inhibitor. Oral are of three types. Some of them inhibit 27910, some of them inhibit only 10, and some of them inhibit only 2. How many of you got this classification? The basis of the classification. Learning the name of drugs is up to you. But this is the classification you have to learn. This is the classification. Okay, now, today I will teach you oral anticoagulants. Okay, and in the next session, we will see the parenteral one. Because oral is very big, people. I will teach you three categories in the oral. Can I start oral? So today I am starting oral. Be interactive, people. Can I start the oral one? So I'm starting the oral anticoagulants. The oral anticoagulants. What's the classification? We will revise it again. So these all I will teach you today, right now. I will divide them in three categories. The 2, 7, 9, 10 inhibitor. Okay. 10 inhibitor and 2 inhibitor. Learn the three categories first. Learn the three categories. What are the three categories? 2, 7, 9, 10 inhibitor, 10, only 10 inhibitor and only 2 inhibitor. Learn their names now. Try to mug up their names. 2, 7, 9, 10 inhibitors are known as Coumarin derivative. Okay, here the main drug is warfarin. But apart from warfarin, three more drugs are there. Bis hydroxycoumarin, okay, acinocumarol or Coumarin, acino, and ethyl bis Coumarin acetate. You have to learn others also. Here we have Rivaroxaban. Here we have Dabigatran. Here Rivaroxaban, here Dabigatran. If you say these clearly, if you pronounce these clearly, you will understand. First, learn the broad categories. These one are blocking which one? Inhibiting which one? 2, 7, 9, 10. This one is inhibiting only 10. This one is inhibiting only 2. First, you learn the broad category. Rivaroxaban is factor 10 inhibitor. Dekho 10. How to write 10 in Roman? Dekho 10 is written like this. Roxa ka X is actually 10. You will never forget now. Okay, Rivaroxaban is 10 inhibitor. Okay, and Dabigatran. Debi ko you can read di. Debi and a di and a double. So it is inhibiting factor 2. Okay, so this is how you can learn. So again, master chart. Take out your notebooks and pen and make it with me. Oral anticoagulants I will cover on one page. One page, the complete oral anticoagulants. On one page in the next session, I will cover complete parenteral anticoagulants. Both are ultra important. Because frequently in your exam, you get question either on warfarin or on heparin. Here the prototype drug is warfarin in the oral one. And in the parenteral one, the prototype drug is heparin. Okay, so let's start the oral. You know the classification. So let's start one by one. Okay, the three categories I will teach you. First, I will teach you Coumarin derivatives. Then I will teach you factor 10 inhibitor. Then I will teach you factor 2 inhibitor. Coumarin say, I mean factor 2, 7, 9, 10 inhibitor. If you do not want to read Coumarin, you can say 2, 7, 9, 10 inhibitor. 10 inhibitor and 2 inhibitor. This is how I'm going to teach you. In each category, you have to tell me the name of the drugs. Okay. You have to tell me the mechanism of action, the dose regulation and monitoring. How we do the monitoring, with PT or with aPTT or with both. How we do the monitoring in each of them. Monitoring is required or not required. Advantages over each other. The uses, the adverse effect, contraindication if applicable, and interaction if applicable. So you have to tell me the biggest category is this one. These two are small. The biggest is this one. So let's start the first category, Coumarin derivative. People, what I'm teaching you today, I'm teaching you the drugs affecting coagulation and anticoagulation. Okay. So there are 5 categories of the drugs I will teach you. Today I already completed the first one, coagulants, and now I started anticoagulants. Anticoagulants are of 2 types, oral, parenteral. These one are oral. So today I will complete oral one. So let's start the Coumarin derivative. Let's start the Coumarin. Enumerate the drugs. I've already enumerated the drugs. There are 4 drugs. The main drug is warfarin. Apart from that, we have bis hydroxycoumarin, bis hydroxycoumarin. We are having acino-coumarin or coumarol, and we are having ethyl bis coumaroacetate. Okay, so coumarin, coumaroacetate or coumarin. So bis hydroxycoumarin, acino-coumarin, ethyl bis coumaroacetate. Apart from warfarin to hai hai. So these are coumarin derivatives. These are the drugs. Okay, warfarin is the prototype. Okay, the longest acting is bis hydroxycoumarin, and the shortest acting is ethyl. You can write down here only. Okay, among the four, this one is prototype. Okay, G. Okay, this one is longest acting. Okay, G. And this one is shortest acting. Here only you can write. You get MCQs on that. So which is prototype? Warfarin. But it is neither longest nor shortest. Okay, the longest one is bis hydroxy and the shortest one is ethyl bis coumaroacetate. Okay, so this is what you have to learn. Mechanism of action. Let's come on the mechanism of action. How does they act? Okay, all the oral anticoagulants, all of them, the oral anticoagulants, all 4, they inhibit this enzyme. Vitamin K epoxide reductase, VKOR. What does VKOR do? I told you what does VKOR do. VKOR क्या करता है? VKOR, this is vitamin K epoxide reductase, activate vitamin K. Okay, from inactive vitamin K, it activate. Now warfarin and all other oral anticoagulants, all 4 anticoagulants, oral anticoagulants, they inhibit this enzyme. So vitamin K is not activated. If vitamin K is not activated, it will remain inactive only. And vitamin K is required for activation of 2, 7, 9, 10. So 2, 7, 9, 10 will not activate it. You are getting my point. What happens normally? Tell me the cycle. So factor number 2, 7, 9, 10, they are inactive because they are having glutamate residue. For their activation, we need carboxylation of their glutamate residue and they will get activated if you are doing the carboxylation. But for this purpose, we need vitamin K. Vitamin K do so very well. But while doing so, the active vitamin K convert into inactive vitamin K. Active vitamin K convert into inactive vitamin K because vitamin K is like a donor. Vitamin K will give its own carboxyl group to them. And they get the carboxyl group and from decarboxylated, they convert to carboxylated. Vitamin K is giving its own carboxyl group to them so that they can activate. But while doing so, the vitamin K itself convert from active to inactive. If you again want to convert its active form for the next cycle, you need an enzyme. The name of the enzyme is vitamin K epoxide reductase, VKER. Warfarin inhibit this enzyme. If this enzyme is inhibited, the vitamin K cannot be activated. Vitamin K will be inactive only. If vitamin K is inactive only, these 4 factors cannot be activated because these 4 factors depend on vitamin K for the activity. So these 4 factors will be inhibited but indirectly. The warfarin do not touch these 4. Warfarin inhibit this enzyme which is required for activation of vitamin K, and vitamin K is required for activation. So basically warfarin is indirect inhibitor of 2,7,9,10. Warfarin is indirect inhibitor of 2,7,9,10. It is not directly inhibiting 2,7,9,10. I told you, na. So this one inhibit 2,7,9,10. They inhibit 2,7,9,10. This one inhibit 10. This one inhibit 2. Okay, but this one is directly inhibiting 10. This one is directly inhibiting 2. This is indirectly inhibiting this 4. Because warfarin or any of the Coumarin derivative do not inhibit them directly. They inhibit the vitamin K epoxide reductase which is required for vitamin K activation. And if there is no vitamin K, they are not activated. So they are indirect inhibitor. Got it? They are indirect inhibitor. Got it? Yes, vitamin K is required for all the cycle. Now, for the next cycle, we have to activate it. But if warfarin is inhibiting it, how the next cycle will happen? Only one cycle will happen and after that it will not happen. So 2,7,9,10 will not be activated and 2,7,9,10 will be missing. So what's the mechanism of action? This is the mechanism. Where is 27910? You can see 27910. So if I'm a patient and I'm taking a tablet of warfarin, the warfarin is going in my mouth, in my esophagus, in my stomach, in my intestine, it will get absorbed. Warfarin will go in my blood. From my blood, the warfarin go in my liver. It will go in my liver. In the liver, it will inhibit vitamin K epoxide reductase. Normally in the liver, this enzyme is required for activation of vitamin K. Now this enzyme is inhibited in the liver. So in the liver, if this enzyme is inhibited, vitamin K will not work in the liver. In the liver, normally vitamin K convert 27910 from inactive to active. Now in the liver, 27910 will remain inactive only because there is no active form of vitamin K to convert them into active form. So 27910 is missing. So there is no 2, no 7, no 9, no 10. If 4 of them are missing, the clot will not form. The secondary clot will not form. The clot will not form, and that's anticoagulation. I want anticoagulation. I'm teaching you the chapter anticoagulation. This is how they achieve anticoagulation. So what does oral anticoagulants will do? Oral anticoagulants inhibit VKOR, vitamin K epoxide reductase, VKER. Since this enzyme is not there, vitamin K will not active. If vitamin K is not active, factor 27910 will not active. The factor 27910 will not work. Their level will drop. Their active level will drop in the blood. And this is how we achieve anticoagulation. People, it's difficult chapter. It is one of the most difficult chapter of pharmacology I'm labeling. So please do understand. You are getting it what we are doing. You are getting it what we are doing. Say, so this is the mechanism of action. But, how should I explain you? See this diagram. What does warfarin is doing? Where is warfarin? Here is warfarin. Coumarin derivative. What does it do? What does it do? Say, ma'am, it is inhibiting 27910, not all 12, only 27910, and that too indirectly, not directly. Okay, so basically warfarin is inhibiting the VKER, that is vitamin K epoxide reductase. So no VKER, no active form of vitamin K, no 27910 activation. But it is inhibiting these 4, but it inhibits the formation of protein C and protein S also. This but matters. You're getting my point. There is a climax in the story. Now this is inhibiting protein C and protein S also. Protein C and protein S are anticoagulants. So basically, when I take a tablet of warfarin, so 27910 ka level fall in my blood. Okay, because 27910 level fall in my blood, I will have anticoagulation. But protein C, protein S level also fall in my blood, and I will have coagulation. So the question is that warfarin is anticoagulant or coagulant? With this, it is both. You will say, warfarin is anticoagulant or it's coagulant. With this mechanism, it is both. It is both. Yes, it is both. You are getting my point. So warfarin, that is oral anticoagulant, it inhibits VKOR. And VKOR is required for activation of 27910. So hey, VKOR is also required for activation of protein C and S. Since there is no VKOR, no 27910, and no protein C, no protein S. No 27910, it means anticoagulation. Okay, and no protein C, no protein S, it means coagulation. People say if you are getting it. So my question to you, warfarin is coagulant or anticoagulant? Warfarin is coagulant or anticoagulant? Say na, say. So the answer for this. So I agree, the level of all fall in the blood. So in my blood, if I'm taking a tablet of warfarin, suppose I'm taking a tablet of warfarin, it will go in my blood. So level of 27910 will also fall, and protein C and protein S will also fall. But protein C and protein S T half is short. So first their level fall. Okay, and their T half is longer. So their T half, the 27910 T half is longer. So their level fall little bit after. Okay, so suppose I am taking the tablet, within 1 hour, protein C and S fall. So first I have coagulation, and later on I have anticoagulation. So when we take warfarin, first there is transient coagulation followed by anticoagulation. We say it's an anticoagulant, yes, but transiently it's coagulant. This question comes in your exam. I tried people explaining you. I don't know whether you got it or not. Say, so protein C and S is having shorter T half as compared to 27910. That's why protein T and S have rapid decline as compared to 27910. So first protein C and S will fall, causing coagulation, and then 27910 will fall, causing anticoagulation. So first there is transient hypercoagulation followed by anticoagulation. So this is indicated over here. You can see this is shown over here. So whenever we take oral anticoagulant, that is warfarin, first there is hypercoagulation transiently followed by anticoagulation. People respond, got it or didn't got it? Say, got it or didn't got it? So this was a catch in the story. This was a catch in the story. So warfarin, as soon as we take the warfarin, initially there is transient hypercoagulation. Okay, followed by anticoagulation. Okay, because as soon as we take the warfarin, first the level of protein C and protein S will fall, and then level of factor 2, 7, 9, 10 will fall. It will fall later on. So first there is hypercoagulation followed by anticoagulation. So basically warfarin is an anticoagulant. It is not a coagulant, but transiently there is coagulation. You must know that. Yes, yes, yes. And you should be able to answer it well in your exam. You can understand it here. So warfarin is inhibiting this as well as this. You see the minus sign. Okay. Now learn 3 more things with the mechanism of action. Number 1, warfarin work in vivo, not in vitro. You know what is vivo? What is vitro? You know what is vivo? What is vitro? Vivo is a living person. This is vivo. And vitro is the test tube. I mean outside the body. Outside the body is known as vitro. Vitro is the test tube. So if I take a tablet of warfarin, okay, if a human, suppose I am a human, if I take a tablet of warfarin, will it show anticoagulation? Yes, because I have the liver. This warfarin will go in my mouth. From the mouth, it will go in my esophagus. From the esophagus, it will go in my intestine. It will absorb. It will go in my blood. From the blood, it will go in my liver. So see, it is going in the liver. The warfarin is going in the liver. How I told you, it will go in the blood. From the blood, it is going to the liver. In the liver, it inhibit the VKER in the liver. This enzyme present in the liver. Since there is no VKER, no vitamin K. No vitamin K, no 2, 7, 9, 10. So basically, it is inhibiting 2, 7, 9, 10 formation in the liver. You are getting my point? Yes or no? But if I am putting a tablet of warfarin in a test tube, okay, in a test tube containing blood, the blood contain 2, 7, 9, 10. Okay, they are inactive. Okay, blood contain 2, 7, but warfarin do not inactivate them. Because for action, warfarin need liver. Warfarin need the enzyme. So warfarin work in vivo, not in vitro. The test tube don't have the liver. I hope you are getting it. The human have the liver. And warfarin need liver to work. Okay, because the enzyme it is inhibiting, it is present in liver, not in the blood. How many of you got this answer? So why warfarin work in vivo, not in vitro? Heparin is opposite. I will teach you the next heparin. Heparin works both in vivo as well as vitro. How many of you got it? That is the first thing you have to learn. The second thing, warfarin. If I'm giving warfarin, what does it do? Say, ma'am, warfarin will inhibit 2, 7, 9, 10. You can see this is inhibiting 2, 7, 9, 10. 2, 7, 9, 10. Warfarin is inhibiting. But it is inhibiting the formation of 2, 7, 9, 10 or activation of 2, 7, 9, 10 in the liver. The activated version in the blood will not affect it. Okay, so suppose this is the human and this is the blood vessel of this human. This is the human and this is the blood vessel of this human. Let's draw the blood vessel. So 2, 7, 9, 10 present here. They are inactive. Okay, warfarin will inhibit their activation. But the 2, 7, 9, 10 already present in blood, warfarin will not affect them. Okay, so warfarin is slow in action. The one, if you give the warfarin, okay, so it will inhibit the formation of new 2, 7, 9, 10. But the 2, 7, 9, 10 already present in the blood, it is sufficient for 2 to 3 days. Okay, so warfarin action is visible after 2 to 3 days. Okay, so warfarin is not a drug of choice for emergency. If you want emergency anticoagulation, heparin is the drug of choice. Warfarin is slow acting. It is required for maintenance, not for initiating therapy. So if you give the warfarin within 2 to 4 hours, it will inhibit the activation of 2, 7, 9, 10, but in liver. But in the plasma, 2, 7, 9, 10 are already present and they are sufficient for 1 to 3 days. So the action of warfarin is after 1 to 3 days. After the administration of the drug, it will need 3 days to show the anticoagulation action. Because the preformed 2, 7, 9, 10 is not affected. The newly formed will be affected. So the oral anticoagulant or warfarin are required for maintenance, not for initiation. For initiation, we need heparin. How many of you got this concept? So this is the second concept. This is the second concept. And third and the last concept, it inhibits 2, 7, 9, 10. 2, 7, 9, 10. But what is the sequence of inhibition? What is the sequence of their fall? All of them will fall in the blood. But first of all, which one will fall? So the shortest half-life is 7. 7 will fall earliest. 7 followed by 10. Followed by 10. Okay. 7 followed by 9. Followed by 10 and then 2. So this is the sequence. What is the sequence, people? What is the sequence of their T half? So if I'm taking a tablet of warfarin, in my blood 2, 7, 9, 10 all will fall. The already present 2, 7, 9, 10 will not fall. Okay, but the newly coming from the liver will fall. So first of all, 7 will fall. 7 will fall. Followed by 9, 10 and then 2. You have to learn the sequence. You have to learn that. So which one is the earliest? The earliest is the 7. Where is 7? Where is 7? Can you locate 7? Where is 7? Locate 7. Here is 7. So 7 is earliest to fall. That's why we measure PT. You know this is PT. We measure PT to observe the response. So So if I'm taking a tablet of warfarin, whether warfarin is working in me or not, shall I measure aPTT or shall I measure PT? Huh? Which one will be prolonged? On taking warfarin, which one will be prolonged? PT will be prolonged or aPTT will be? Both will be prolonged, but first PT will be prolonged because earliest to fall is 7. 7. Okay, 2, 9, 10 will also fall, but later on. First 7 will fall. Since 7 will fall first, PT will be prolonged. So if I'm taking a tablet of warfarin and you are a doctor, you want to see whether the tablet is working in me or not, you measure my PT. Okay, so dose regulation is done by PT, not with aPTT. This is the reason. It's a completely conceptual chapter, people. I'm trying very hard to give you all the concepts. Okay, so we measure PT and INR. What is INR? INR is the ratio of PT only. So we measure PT. The reason I have given you, because the earliest factor to fall is factor 7. So factor 7 is earliest and factor 7 is a factor for extrinsic pathway. And in extrinsic pathway, we measure PT. That's why the response is measured with PT. You are getting it? So response is measured with PT. 7 is the earliest to fall. And that's why we measure PT. Later on, these three will also fall and aPTT will also prolong. Okay, but first PT will prolong. So if I take a warfarin, first my PT will prolong and then aPTT will prolong. You are getting my point? And second, we take the INR. What is INR? INR is the ratio of PT of patient and PT of reference. Okay, PT of patient upon PT of reference. This ratio is INR. Either you just measure PT of the patient or you do the ratio of patient with the reference. It is INR. So PT, so better than measuring alone PT, you do the ratio. Here you are just measuring PT of the patient. Okay, PT of the patient. Here you are just measuring PT of the patient. Here, along with measuring PT of the patient, you are comparing it with PT of the reference. This is INR. So this is a better for dose monitoring. So dose monitoring is done by two ways, PT and INR, and these are the universal guidelines. So INR, if you are giving the treatment for deep vein thrombosis, if you are giving the treatment for deep vein, if you are giving the prophylaxis for deep vein thrombosis, you have to give such a dose that is maintaining the INR 2 to 2.5. Okay, if you are giving treatment of deep vein thrombosis, you have to maintain the INR 2 to 3. And if the patient is having recurrent thrombosis, they all are thrombosis. But this is prophylaxis, this is treatment, this is recurrent. So here INR should be maintained 3 to 3.5. You are getting my point? What I am saying? You are getting my point? I am a patient. I am coming to you. Doctor, I was having DVT, but now I don't have, but I do not want in future also. Give me some prophylaxis. So you will give me warfarin. Warfarin prevent the thrombus formation in me. DVT is deep vein thrombosis. The thrombus is formed in the leg. Okay, so these are the leg veins. Even without injury, the thrombus is formed. So I already have the thrombus once. Now I don't have it, but in future I do not want it. So you give me warfarin. What is warfarin? Warfarin inhibit 2, 7, 9, 10. If there is no 2, 7, 9, 10, the thrombus will not form. Okay, it is indirect inhibitor of 2, 7, 9, 10. So thrombus will not form. But here, how much warfarin you will give me? What is the dose? The dose is important. People, these are double-edged sword. On one point, you want to inhibit the formation of the thrombus. But if you give overdose, the bleeding will occur. The bleeding is the most important side effect. The dose regulation is ultra important key here. You're getting my point? The exact dose you have to give. If you are giving underdose, the disease will not treat. And if you give overdose, the bleeding is the side effect. Okay, the side effect will be bleeding. So you have to inhibit 2, 7, 9, 10. लेकिन उतना ही inhibit करना है जितना जरूरी है. You want to inhibit 2, 7, 9, 10 so that clot do not form without injury. But clot should form when injury occur. You do not make it zero. There is no 2, 7, 9, 10. It is zero. So even with injury, there is no clot. So patient will have bleeding. So you have to inhibit it in a regulated way. I hope you are understanding. So that is measured with INR. So patient on warfarin, every week they have to measure their INR. And we have to keep the dose so that their INR is in range. Okay, we can increase or decrease the dose of the tablet by looking at the report of the INR. So if I am giving for the prophylaxis of DVT, I will give in low dose. If I give for the treatment, I will give a little bit higher dose. And if there is recurrent DVT, I will give even higher dose to maintain that. Respond, people. Are you getting it? So these are the guidelines. So if you are giving for prophylaxis of DVT or treatment of DVT or recurrent DVT, DVT is thrombus in the leg, deep vein thrombosis. So for what purpose you are giving? So the dose will be according to that. Here the INR is maintained between 2 to 2.5, here 3, and here 3 to 3.5. This is how you have to learn it. How many of you got it? So that is the mechanism of action. So I taught you mechanism of action with the 3 important things in mechanism of action. Can we revise? I'm teaching you oral anticoagulants. Oral anticoagulants, I am teaching you there are 3 types of oral. Okay, I'm teaching you the one which indirect inhibitor of 27910. Okay, that is Coumarin derivative. After that, I will teach you direct TAN inhibitor and direct 2 inhibitor. These two I will teach you right now. I will teach you these two also. But currently, I'm teaching you Coumarin derivative, which are indirect inhibitor of 27910. So tell me their mechanism of action. How does Coumarin derivative, the prototype drug is warfarin, attack? So warfarin inhibit vitamin K epoxide reductase in liver. In liver, this enzyme is inhibited. Since this enzyme do not work, it do not convert inactive vitamin K to active vitamin K. So vitamin K is not activated. Since vitamin K is not activated, 2, 7, 9, 10 will not activate it, because for the activation of these four, vitamin K is required. So basically warfarin indirectly inhibiting 2, 7, 9, 10 in the liver. But warfarin do not affect the preformed 2, 7, 9, 10. This is the mechanism of action. Now in mechanism of action, you have to learn three things. Warfarin act in vivo, but not in vitro. I have explained why. You should be able to draw the flowchart and explain why. Warfarin work in vivo, not in vitro. Warfarin is given for maintenance therapy, not for emergency initial therapy. Because warfarin is slow in action, it needs 1 to 3 days to show its anticoagulant action. Number 2. Okay, and number 3, warfarin ke liye we measure PT, not aPTT. You should be able to explain it, because the shortest half-life among them is of 7. So 7 fall earliest. 7 fall earliest. How many of you got it? How many of you got it, people? So this is what I taught you till now. Okay, if you are not responding, let me proceed. So coming on the uses. What are the uses? Warfarin is given for maintenance therapy, not for initiation therapy. For initiation, we give heparin. So basically, we start the two together. We start warfarin and heparin together. We give a cover for heparin for 1 week. And after 1 week, we withhold heparin and we continue warfarin. Because within 1 week, warfarin will come in the role. You are getting my point? So we start both. So when a patient with thrombosis is coming with me, okay, so I will give both. I will start warfarin ka tablet and heparin ka injection. Heparin is subcutaneous injection. Okay, heparin is injectable. Heparin is injectable. Okay, it's parenteral. This one is oral. So I will start injection as well as tablet. This I will continue for 3 to 7 days till this will come in action. Okay, so this is given for initiation therapy. This is given for maintenance therapy. What are the uses? In these 7 conditions, I will give it. You can see this is thrombosis. This is also thrombosis. So for treatment of thrombosis, for prophylaxis of thrombosis. Okay, what is MI? What happens in MI? In MI, the most common cause of MI is thrombus in the coronary artery. There is a thrombus or embolia in the coronary artery. So in MI also we will give for the prophylaxis of the next attack. In angina also we will give it. Angina, maybe the pathophysiology is same. You have to understand the pathology of all of them. The pathophysiology is in angina is the thrombus in the coronary artery. Okay. For atrial fibrillation, we can give it. For vascular surgery, prosthetic heart walls, to prevent the thrombus formation, hemodialysis, we can give it. And in DIC, yesterday I taught you DIC, I can give it. So these are the indication for the prophylaxis of DVT. Okay. For the prophylaxis of DVT. For the treatment of DVT. For MI, for angina, okay, for MI, for angina, for DIC, okay, in hemodialysis or prosthetic wall surgery to prevent the thrombus. So basically, I do not want thrombus. If it is already there, I will give it for treatment, and if it is once there for the prophylaxis also, I will give it. So these are the uses. Adverse effects are only 3. Let's come on the adverse effect. Bleeding, alopecia, and dermatitis. One by one, we will see it. The first is the bleeding. You know, little bit dose is increased. If you are not monitoring INR closely, the person will bleed. The person will bleed. You want to inhibit 2, 7, 9, 10, but to such a level that thrombus do not form. You do not want to make their level 0, so that even if the person have injury, the bleeding will occur. Suppose I am a person, actually I am a person, but suppose I am having the thrombus anywhere in my body. Suppose most common location of thrombus is the leg veins. In my leg, in my deep veins on my leg, I am having thrombus. The name of the disease is DVT. I'm coming to you. Doctor, I'm having DVT. Okay. So I'm having DVT. So what is the DVT? In DVT, my blood vessels, without injury, I have the clot formation. Multiple clots in my deep vein without injury. Okay. You do not want to it form again. The already formed one is not dissolved by the warfarin. For that, you have to give the fibrinolytic therapy. I will come on to it. But the new one should not form. The new one. For that, you are asking me to take a tablet of warfarin daily. What the warfarin will do? Warfarin will fall the level of 2, 7, 9, 10. But how much fall? I want the fall to such a level that without injury, clot do not form. But suppose I got a cut. I have DVT, but I can have cut also. I can have injury also. Suppose I am having injury, so I will bleed. But I want the clot form at that time. For formation of clot, I need 2, 7, 9, 10. So 2, 7, 9, 10 level should fall to such a level that without injury, clot do not form. But with injury will form. But if you give high dose of warfarin, their level become almost zero. So even with injury, bleeding will occur and clot will not form. So bleeding is the most common side effect. Okay, bleeding is the most common side effect. Okay, so bleeding can be the most common side effect, the extension of the desired pharmacological action. Okay, it is the extension of desired pharmacological action. The bleeding can be from the nose, from the urine, in the GIT. Bleeding can be any form. It is not only nasal bleeding. It can be any, from the ears, in the conjunctiva. It can be internal bleeding. It can be external. Sometimes it can be intracranial bleeding. Bleeding is dangerous. So treatment. Suppose I'm a patient and I'm having DVT. You are my doctor. You are my hematologist, and you are giving me, asking me to take warfarin tablet. I'm taking warfarin. You ask me, madam, after 3 days, you do your INR and send the report to me. I will adjust your dose. But I am reluctant. I am not doing the INR and not sending the report. Doctor तो ऐसे ही बोलते रहते हैं, क्या होगा? I'm taking the same dose, but that dose is overdose for me. Okay, actually, I have not done the report. If I had done the report, you may have adjusted my dose. I'm taking the, and I start bleeding. At 2 o'clock at night, at 2 a.m., you got a call. The doctor, I'm having nose bleeding, anywhere bleeding, internal bleeding, external bleeding. It's an emergency. Stop warfarin. Stop warfarin. The first thing, stop warfarin. Give fresh blood, which contain 27910, which contain all 12, including 27910. Why I'm bleeding? Because my blood do not have zero level of 27910. Warfarin ka overdose. We want to reduce 27910. We do not want to make it zero. But if warfarin overdose is there, 27910 will be zero and I will bleeding. Okay, so give fresh blood because it is having ready-made all 12, including 27910. Give ready-made fresh blood and give K1, artificial K1. You know what does K1? K1 will help in formation of 27910 because warfarin, via warfarin, you have inhibited K1 now. So now give new K1, okay, and withhold warfarin. So this is the treatment for the bleeding. The second side effect is alopecia. Warfarin or oral anticoagulants cause patchy alopecia, the fall of hair, patchy alopecia. And third, skin necrosis. Why they cause skin necrosis? I taught you, warfarin inhibit 27910. Their level fall, but warfarin also inhibit protein C and protein S. Yes or no? Before falling level of 27910, the level of protein C and S fall. They have even shorter half-life than 27910. So first there is hypercoagulation and then there is anticoagulation. Have I taught you? Because of hypercoagulation, most common hypercoagulation occurs in the skin capillaries. The skin capillary will have the thrombus if prolonged course of warfarin is given. The skin capillary have the thrombus and because of which the skin will have the necrosis. Okay, it is due to protein C and protein S. Hypercoagulation, which precedes. So thrombosis of the skin vessels can occur. It's complicated to understand. I'm talking both ways. It's a bi-jet SWOT. So this was the warfarin. So there are certain contraindication. Don't give if the person already have bleeding disorder. That will be exaggerated. Okay, don't give if the person already have thrombocytopenia. So person will have exaggerated bleeding. Don't give if the person is having risk of hypertension. Okay, the person heart is, subacute bacterial endocarditis. Don't give an alcoholic cirrhosis in which the liver is subnormal. Okay, and don't give it with any other antiplatelet drug. These are the contraindication. Okay, the last is the pregnancy. Pregnancy may don't give warfarin. Heparin is allowed in pregnancy, warfarin is not allowed. Sometimes in pregnancy, DVT is very common. Okay, but in pregnancy, warfarin is not given because it is teratogenic for the fetus. It causes fetal warfarin syndrome. The fetus will not have the eye socket, absent eye socket, hypoplasia of the nose, hands and both bone growth retardation. Okay, so never give warfarin in pregnancy. Heparin is safe in pregnancy. Warfarin is not. Warfarin is not. Infractions you can skip. Okay, that's all about the warfarin. That's all about the warfarin. How many of you got it? How many of you got it? How many of you got it? Varicose vein is different, Ramaya. I will teach you varicose vein there in the pathology when I will teach you the blood vessels. Currently, we are talking about the thrombus in the vein. That is known as DVT. Okay, yes. Absolutely right, Tejas. Atherosclerosis is the most common cause in MI and angina, but it can be thrombus also. Not most common. Maybe I have said the most common, but thrombus is also cause. Anything obstructing the coronary artery can lead to MI and angina. Maybe it's atherosclerosis, which is made up of cholesterol cleft, or maybe it's a thrombus or embolism, which is obstructing. So obstruction in the blood flow of the coronary artery is important for causing angina and MI. Got it, Tejas? Can we go ahead? Can I start the next drug? So these are 2, 7, 9, 10 inhibitors. That too indirect inhibitor. Now I'm telling you 10 inhibitor, direct 10 inhibitor. Let's start direct 10 inhibitor. Tell me the drugs. So here we have only one drug. Rivaroxaban. Split it. Rivaroxaban. What is Riva? Riva ka matlab hai reversible. It's reversible. Okay. Rivaroxaban. roxa, o का मतलब है oral, okay. za का मतलब है factor 10A, 10A is za, और ban मतलब blocker. So it's reversible oral 10A blocker. You can read like this. Rivaroxaban. Okay, Riva mane reversible. Okay, O mane oral. This is 10A, 10A, and ban यानी blocker. So Rivaroxaban, it's reversible oral 10A blocker. उसके नाम में ही उसका मतलब है. The name itself showing its meaning. Okay, so Rivaroxaban directly inhibit factor 10. Where is factor 10? Directly inhibit. Where is factor 10? Directly gone. Factor 10 directly gone. Factor 10 directly gone. Without vitamin K, directly inhibit. Okay, directly. Not 2, 7, 9, 10. Only 10. Only 10. Now you tell me, use your common sense. Shall I measure PT to monitor or shall I measure aPTT? Shall I measure PT or aPTT? I was measuring PT in Warfarin. Shall I measure PT or aPTT? So obviously here aPTT will be. But here monitoring is usually not required. But if you want it, do it with aPTT. How many of you got it? The advantages over Warfarin is that it acts rapidly. It acts rapidly because it directly inhibiting factor 10. No lab monitoring is required because it is not inhibiting 4. It is inhibiting only 110. Because if it is inhibiting 4, it's risky. It can cause bleeding. So you have to do monitoring every week, every third day, PT-INR, PT-INR. But here monitoring is not required even for 1 month. Patient can take the same dose because it is inhibiting only 10. So risk of bleeding is less. Risk of bleeding is less. And effect is same. Effect is same. That is the advantages. Use prophylaxis and treatment of DVT. Only one use. Adverse effect, bleeding can happen. Although the chances are less as compared to warfarin, but it can happen. Along with that, nausea, hypotension, tachycardia, edema, non-specific side effects, but bleeding can happen. The last one is 2 inhibitor. This is 10 inhibitor, not 2 inhibitor. In 2 inhibitor, we have only one drug, Dabigatran. Dabigatran, it exhalate. Dabigatran, it exhalate. So Dabigatran is a prodrug. After going in the body, Dabigatran convert into its active form. Dabigatran acetylate is a prodrug. After going in the body, it converts into active form Dabigatran. Acetylate hat jayega. It is only Dabigatran, and Dabigatran inhibit 2. Where is 2? Where is 2? Here is 2. So 2 is inhibited. It is inhibiting only 2. It is inhibiting 2, only 2. Again, it's very rapid, okay, because it is directly inhibiting 2. No lab monitoring is required. No PT monitoring because it is inhibiting 2, 7, 9, 10 में से only 2. So warfarin inhibit 2, 7, 9, 10. 2, 7, 9, 10. Okay, Rivaroxaban inhibit only 10. And Dabigatran inhibit only 2. So only 10 and only 2 wale safe hain. There are less chance of bleeding, so monitoring is not required. But the one which is inhibiting all 4, that is dangerous. And here the monitoring is required. The use is same. It is given in DVT. Adverse effect is same, bleeding, but it can cause hepatobiliary disorders. So you have to learn the specific adverse effects. We are done, people. We are done. So I taught you oral anticoagulants. I taught you 3 oral anticoagulants. I taught you indirect 2, 7, 9, 10 inhibitor, direct 10 inhibitor, direct 2 inhibitor. This is indirect 2, 7, 9, 10 inhibitor, direct 10 inhibitor, direct 2 inhibitor. The main drug here is warfarin. Okay, there are many, but the main is warfarin. You should learn all. Here only one drug, Rivaroxaban. Here only one drug, Dabigatran acetylate. Done. Okay, this is indirect via vitamin K. This is direct, this is direct. Since this one is inhibiting 4, it's risky. That's why PT and INR monitoring is required. Okay, these are inhibiting only 10 and only 2. So they are less risky. Even if you want to monitor, you have to monitor aPTT, but monitoring is not required. People say, I'm done. You can see. It's in front of you. Can you see it? Respond. Coumarin derivative. Inhibit 2, 7, 9, 10. Okay. Rivaroxaban inhibit only 10. Okay. And Dabigatran acetylate inhibit only 2. It's in front of you. But this inhibition is direct. This is not direct. This is indirectly via vitamin K. I tried. I hope I am done. So I'm done with the oral anticoagulants, people. I'm done with this portion. This portion I will take in the next session.